All right, so just as everyone else is still signing in, we did want to go over just a few housekeeping notes before we get started. So we do encourage you to use the chat feature if you have any comments throughout the presentation. If you do have specific questions that you would like answered, please be sure to submit them in the Q&A box on the bottom of your screen. We will hold off on asking them until the end of the presentation, but we will be sure that they get addressed. And then a reminder to anyone today who is attending for CME credit, you must make sure that you attend for a full 60 minutes. And then tomorrow, our marketing team will send an email to whatever email address you registered with. So an evaluation form will be sent to that email. You will need to complete the evaluation form and then send the email back to us. My email is listed at the top of the evaluation form, so please be sure to send it back in order to get CME credit. So again, that'll be attending for 60 minutes and then filling out that form. And then if you are a board certified pediatrician and you attend and fill out the form and you list out your board certification number, you will be eligible, again, if you're board certified in pediatrics, to get MOC credit as well. So other than that, I will now introduce Dr. Caravella. He is our Chief Quality Officer here at Allied Physicians Group. And I will hand it over to him and he will introduce our speaker for this evening, Dr. Paul. Thank you. Oh, you're on mute, Dr. Caravella, sorry.
Okay, thank you. Good evening and welcome. Thank you all for attending Allied Physician Group's educational series for 2023. Tonight's topic, concussions, diagnosis, treatment, and prevention, is timely as we emerge from the pandemic and our children return to their regular activities. Concussions after a head injury among children continues to be a substantial public health concern. An increasing number of concussions is being managed initially by primary care physicians. The diagnosis of concussion remains a clinical diagnosis despite the availability of ancillary tests, such as computerized neurophysiological testing, advanced imaging, and blood biomarkers. Tonight's speaker, Dr. Audrey Paul, will present an evidence-based guide to concussion diagnosis on and off the playing field, concussion treatment, and guidance on return to learn and sports protocols. Dr. Paul is double board certified in both pediatrics and emergency pediatric medicine. She received her undergraduate degree in biochemistry from Harvard College and completed her medical and residency training at the Mount Sinai School of Medicine in New York. Dr. Paul received fellowship training in pediatric emergency medicine at Columbia Presbyterian. Dr. Paul is well known and has lectured extensively regarding concussion diagnosis and management. As a researcher, Dr. Paul has received grants from the American College of Emergency Physicians to evaluate the quality of discharge instructions for pediatric concussion in pediatric and adult emergency departments, and this is a nationwide review. Currently, Dr. Paul is a clinical associate professor of emergency medicine at NYU Long Island and the alternate chancellor for the American College of Emergency Physicians Pediatric Emergency Medicine Committee. She has served as chair of the Pediatric Emergency Medicine section for the ACEP. As a clinician, Dr. Paul is PALS, BLS, and ACLS certified and is a credentialed impact consultant. Please welcome Dr. Audrey Paul.
Thank you for that very amazing introduction. I appreciate that. And thank you for inviting me here today to talk about a subject that's near and dear to my heart, which is concussion management. So I actually became interested in the field of concussion kind of basically through two different routes. One was academic and the other one was personal. On an academic note, when I had worked 10 years ago, I used to work at Mount Sinai in the pediatric emergency department, and I was asked to lecture about concussion management. And I had asked a group of emergency physicians about when they would decide to tell and ask, a patient that they could return to play after visiting the emergency department for a concussion. And I got any number of answers, anywhere from a day, 2 weeks, 3 weeks. And I realized that nobody had actually given the right answer, which is you first have to be cleared by your primary care physician in order to return to play. And I found that there's at this disparity in knowledge wasn't just limited to the emergency department, but seemed to be pretty widespread in terms of the pediatric community at large. And so I became much more interested in advocacy and education for concussion management. Around the same time, we actually decided to make the move from New York City out to Connecticut because my son plays a lot of ice hockey and he's a goaltender. And he had actually sustained a couple of concussions, and his recovery was, to me as a parent and as a pediatrician, fraught with confusing answers, different management strategies, and a lot of frustration on my part. And I realized actually that there was a real need for some kind of concussion expertise in my community. So I ended up opening a practice called Advanced Concussion Solutions up in Westport, Connecticut, and then opened a second office in Garden City. So, now I actually combine my two passions of concussion education, management, and advocacy, both in the emergency department and in private practice. So the objectives of my talk today are to understand the definition of concussions and what diagnostic tools are available to us today for concussion management. To discuss the acute management of newly concussed patients. So these are patients who may present to you in your office, sometimes even the same day after an injury or within 24 to 48 hours after injury. Just to discourage, not so much discharge planning, but sort of like, I guess, discharge planning from the office and sort of how concussed patients should be followed and how we can clear these patients for sports or for school or for work. If they're, sometimes you'll see, even in a pediatric practice, you'll see patients who are even in their early 20s. So work clearance actually becomes very important. And this isn't as much of a problem now, although since COVID has officially ended, but there's still some challenges, in terms of COVID, because the world of COVID has led to us having many more hours in front of computer screens, and including now, for example, like Zoom lectures 3-4 years ago would have never happened. And now a lot more schooling and education is actually done in front of the computer screens. So sort of one of the fallouts from COVID is a lot more screen time than students previously had. So just wanted to start with some true or false questions. Try to figure out if people can answer this by chat or somehow respond, but true or false, concussions can be diagnosed by CT scan or MRI. So the answer would be false. Concussions can be diagnosed neither by CT scan nor MRI. Currently, there's no standardized neuroimaging that's really validated for concussion diagnosis. Concussions can be prevented by appropriate helmets. And we all know that helmets are amazing for preventing more serious traumatic brain injury, but don't prevent concussion. Concussions are always associated with loss of consciousness. Actually, only 10% of concussions are associated with loss of consciousness. Most concussions are not. And concussions are treated by extended rest and avoidance of activity. So this kind of protocol had been known as cocooning, and we used to have patients basically stay in a dark room without any activity until they started to feel better. And this has been shown time and time again through evidence-based research to be untrue. So we do know that concussions are very common, partly because of the number of kids who play sports and just the number of injuries resulting from those sports. So more than 60 million children play sports in the US every year. And from those 60 million children, we see an estimated 3.8 million concussions from sports and recreation each year. And those are the ones that are reported. Many concussions even go unreported. About 250,000 pediatric emergency department visits occur for concussion annually. So obviously, understanding how to diagnose and manage concussions is of tantamount importance. So what is a concussion? I've always felt that the less you understand something, the more words you have to use to actually define it. So obviously, just from the length of this definition, we can see that we still don't fully, completely understand what a concussion is, but it is defined as a brain injury that's caused by a complex pathophysiologic process. And it's affecting the brain that's induced by biomechanical forces. Now, the big part of this is that concussions must be caused by a direct or an indirect impact to the brain. So you can see concussions from indirect impact. For example, I had a patient the other day who got hit in the face with a field hockey stick and sustained an injury to their jaw, but they never were struck directly to the head, but just from the actual impact to the jaw, they ended up sustaining a concussion. Often you'll see patients who come in for motor vehicle accidents who have whiplash type injuries, and those can present as concussions. And concussions are actually physiologically are thought to be due to a brain energy mismatch. Any questions so far? Okay, so I'm going to continue. So the features that are associated with concussion include, as we said, it can be caused by a direct or indirect blow to the head, and it typically results in a rapid onset of short-lived impairment that resolves spontaneously. So a lot of times you'll see kids on the playing field, they'll say they were struck, they felt kind of out of it, dizzy, confused, and a lot of times those symptoms will resolve pretty rapidly, but in certain cases, those symptoms can evolve over a number of minutes to hours. And actually, I've noticed that in younger patients, those symptoms can actually take 24 to 48 hours to evolve. So often you'll have a 9 or 10-year-old who will come to your office 1 or 2 days later after having sustained a head injury during a soccer game or some other sports game, and they'll be fine at that time, but they develop the headache in the next day or so. So it's always good to be aware of that. And it's important to know that concussion is a functional and not a structural disturbance, which is in part why we have so much trouble seeing this on MRI or CT scan. And finally, concussion results in a graded set of clinical symptoms that may or may not involve loss of consciousness, and recovery in about 20% of cases can actually be prolonged. So what about the pathophysiology of concussions? Sorry. So concussion has actually, so neuroscience, a lot of research has shown that concussed neurons will leak potassium and neurotransmitters. And what happens is a neuron runs out of ATP in an offer to restore cellular homeostasis. And this is in the setting of dysfunctional mitochondria and decreased blood flow. So essentially you have a situation where the mitochondria can't generate enough ATP to fuel the sodium potassium ATP pumps in the cell membrane. And so this results in worsening dysfunction. And so what happens ultimately is the neurons reach a sort of energy crisis where they're unable to produce enough energy to restore homeostasis within the cell. And solving this energy crisis is the principle behind concussion rehabilitation. And this is an example of the neurometabolic cascade of traumatic brain injury. So we can see here how during the neuron will get stretched, and then you'll have this massive ion influx and efflux. So ion influx of calcium results in protease activation and cell death, and glutamate and extrusion of glutamate. And because of damage to the neuron, this results in delayed neurotransmission, which actually manifests as many of the symptoms that we see. And this is just another summary of what happens during a concussion. So what happens is an axonal insult results in this initial hypermetabolic state followed by a hypometabolic state. And so the symptoms that result from this pathophysiology include migraine headaches, vulnerability to secondary injury. The impaired transmission results in slowed processing. So many concussed patients describe feeling foggy or slowed down or having difficulty with short or long-term memory. And chronic symptoms can result in persistent impairment. So I don't know how many of you are hockey fans, but here's an example of Sidney Crosby, who was a hockey player for the Pittsburgh Penguins. And he had actually sustained a number of concussions. And he had described concussions as something that's hard to explain. He felt off, headachy, a little sick. A lot of patients will describe feeling foggy. They'll feel very fatigued. And really, and interesting, many patients will describe what's considered to be sort of emotional lability. So a lot of patients will come in and they'll just cry for no reason. They'll feel sad. They'll feel depressed. And it's important to reassure your concussion patients that those symptoms are common and do resolve over time. So there are 4 categories of symptoms. These include physical, sleep, cognitive, and emotional. So the emotional symptoms that we've described include anxiety, nervousness. In younger children, you can see clinginess, depression, emotional lability, irritability, personality changes, and sadness. It's always very important to actually screen your patients for depression, because Sometimes patients may not actually express that they're depressed, and the depression can be from the concussion itself and also from the circumstances of not being able to participate in their daily activities, go to classes. They're stressed about making up schoolwork. And so you always want to make screen for any kind of severe depression, just to be aware of that. Cognitive symptoms. These are very common, and they include amnesia, confusion, trouble concentrating, trouble remembering, especially short-term memory. Patients will describe feeling really slowed down. They'll kind of feel out of it. They'll often complain about many sleep disruptions, so they can't fall asleep. Once they fall asleep, they have vivid dreams. They can't stay asleep. Some patients will sleep for 16 to 18 hours a day. I know when my son was concussed, he would literally sleep for 16 hours a day. So it's actually, and one of the important things with sleep is you want to make sure that patients are sleeping at night and not during the day, because what happens is over time you can end up with a disrupted circadian rhythm, and then it becomes very difficult to reset patients to like a normal nighttime sleep pattern. Physical symptoms include blurry vision, double vision, seizures, sometimes post-traumatic seizures. Dizziness is very common. The most common physical symptom associated with concussion is headache, but there can be vomiting as well, light sensitivity, noise sensitivity, tinnitus, and it's important to screen for all of these symptoms with your patients. One of the things I didn't include here is neck pain, because sometimes you can have what's called a cervicogenic concussion, so you always want to screen for that as well. As I said, loss of consciousness is not a very common finding. Only 10% of concussion patients report loss of consciousness. So classifying concussions, one of the most common questions that I get asked is in my office is like, do you think my child's concussion is moderate? Is it severe? How would you grade them? So there's really no grading system for concussions. And I say that, that's true because I'll have patients who come in to see me who are they're severely symptomatic after an initial concussion. Some of them, they barely can eat, they're walking in with sunglasses, they have severe headaches, and within 3 days, those patients are fine. And then I have another subset of patients who actually have milder symptoms. They seem functional, but their symptoms can go on for months on end. So it's really difficult to actually classify concussions in terms of severity grading. Each patient does experience a unique constellation of symptoms, and that constellation of symptoms should guide their rehabilitation. But even though each concussion is unique, there are different subtypes that can guide therapy. And so the subtypes, and there was actually there's a great study, actually more like a review paper done by Angela Lumba-Brown that talked about the concussion subtypes and associated conditions. And so these include cognitive, ocular motor, headache or migraine, anxiety and mood, and you can have associated conditions like sleep and also cervical strain. And so by classifying your patient into one of these subtypes, you can actually help guide their recovery. So diagnosis in the ER or in your private practice. I mean, so patients will come in after, they'll collide with another player, they fall to the ground, they come in. One of the biggest things is trying to diagnose whether your patient has had a concussion or not. So look up, look down, quit messing around. Does he have a concussion or not? So there are different sideline assessment tools that athletic trainers will often use for concussion, and you'll hear these tests in your office as well. Sometimes patients may actually come in with a copy of the SCAT-5 that the athletic trainer had provided. Sometimes they can come in with what are called VOMS data, which we'll go through, or the King-Devick test. So concussion assessment, first of all, in the ER and in your office, you want to determine the events surrounding the injury. So you want to make sure that the patient didn't have the event didn't correlate with possibly a much more severe traumatic brain injury, like they fell from a large height. Let's say it was an equestrian event, they fell off a horse. They would be at risk for traumatic brain injury, and you might want to obtain a head CT. And you want to also assess risk factors for prolonged recovery and evaluate for concussion symptoms, and you want to perform a concussion physical exam. So one of the things you want to do is you want to ask, and I always ask about this because you want to see, first of all, if they sustained a second injury after the initial concussion. So if you have a patient who is on the playing field, they sustained an initial concussion and then they continued playing and then got hit in the head again, those patients actually have a 8-fold higher risk of prolonged recovery. So it's very important that patients get off the playing field immediately after sustaining a suspected concussion. You want to know if they had any dizziness at the time of injury, if they had amnesia, a recent prior concussion, any history of migraines, prolonged loss of consciousness, or seizure. Any of these factors will puts your patient at risk for a more prolonged recovery. You also want to assess for signs of intracranial injury. Concussion is defined as a GCS of 13 or greater, but honestly, if anybody has a GCS of 15 or lower, I would recommend getting a head CT. And obviously this is outside the scope of this lecture, but there are PCARN rules which help us decide whether to obtain a head CT for kids or not. As I was saying, risk factors prolonged recovery, and these risk factors might guide you in terms of whether you decide that you want to refer your patient to a concussion specialist or manage these patients in your office. But things like anterograde amnesia, as I said, dizziness at the time of injury. The other thing would be a history of visual issues such as convergence insufficiency. So if you have a patient who even before the concussion had required prism glasses, maybe needed vision therapy for convergence insufficiency, those patients tend to have a longer recovery time. Having a history of migraines, anxiety, or depression, female athletes tend to have a higher risk for prolonged recovery. And this is actually really important. Younger kids have a higher risk for prolonged recovery. I would say on average, kids that come to see me that are under like around 8, 9, 10 years of age, on average will take about 3 to 4 weeks to recover from their concussion. Interestingly, having a history of learning issues such as ADHD is not linked to prolonged recovery. Does anybody have any questions so far, or?
We'll save them until the end, Dr. Paul, just so that way we don't interrupt you.
Okay.
Thank you.
Okay, so there are different checklists that we can use for concussion symptoms. So there's something called the ACE, which is actually very helpful for looking at symptoms. And you have the physical, cognitive, and sleep. And this is a nice checklist that can help you remember to go through each of the symptoms. And these include headache, nausea, vomiting, balance problems, dizziness, and you can go through each of these with your patient. In terms of grading, so we did say that you can't really grade concussions, but generally speaking, patients who present with lower symptom scores tend to have a higher likelihood of more rapid recovery. So generally speaking, the more symptomatic you are, the more likely it is that you'll have a more prolonged recovery. So what is a concussion physical exam? Obviously, one of the biggest parts of doing a concussion exam is really doing a thorough neurologic exam. So you want to make sure there's nothing that's on your exam that would want to make you send your patient to the emergency department for neuroimaging, such as a CT scan or MRI. After that, you want to do some brief cognitive testing. You want to assess for which you can do through the SCAT exam. So you can test for short-term memory. You can do numbers in reverse as well as word recall, and have patients do simple, numbers like they can do subtraction in reverse if they're old enough to, like sevens in reverse if they're old enough to do that. You want to do a cervical spine exam, and this is a very important part of your physical exam. If you don't do a cervical spine exam, you can miss a significant percentage of patients who come to see you who may have a cervicogenic concussion. And those concussions can be easily treated through manual therapy and physical therapy. You want to do an oculomotor exam, and we're going to discuss this in a little bit, but this basically will look at visual tracking, looking at smooth pursuits, horizontal saccades, vertical saccades. You want to look at visual motor sensitivity as well. The vestibular exam, you want to do a tandem gait with patients' eyes open and eyes closed, and do what we call a Bess exam. So you'll have the patient stand with their eyes closed, feet together, one foot in front of the other and on one leg, and then you look for the number of errors. And doing this complete physical exam will help you assess whether your patient is concussed, and also will give you a sense of whether they need physical therapy or not. In the future, we hope that there's going to be rapid blood or salivary testing that's available for concussion, but the data on that is very much all over the place and seems to correlate more with more serious traumatic brain injury than it does with concussion. So cognitive screening, as I said before, you can do the sideline assessment of concussion questions, which are on the SCAT, and these include orientation, immediate memory, delayed recall, and concentration, and you can do a mini mental status examination. As I said before, in addition to you should do a thorough neurologic exam. On your head exam, you want to do palpation of the skull, facial bones, You want to evaluate the tympanic membrane for signs of hemotympanum or rupture. On your cervical spine exam, you want to evaluate for bony tenderness, paraspinal or suboccipital tenderness, and you want to make sure that your patient has full active range of motion without pain. So in terms of vestibular function, so the vestibular exam is a very important part of your concussion assessment. And one of the things I want to say is that that's really interesting about the physical exam versus just going through a symptom screen. You can have your patient, I've had many patients come to my office and who said that they're ready to be cleared and they feel fine and that they don't have any concussion symptoms. So if you go through your symptom score, the initial symptom score is going to be 0. They're totally fine. They can go back to play. When you then go through a lot of provocative testing, looking at visual tracking, seeing if any of the symptoms provoke dizziness or headache, and suddenly you see like, oh, now they suddenly have headache with horizontal saccadic movements or smooth tracking. Now you can't really clear them because you see they are still concussed to a certain degree. Excuse me. So for vestibular function, there are 2 parts of our vestibular system, very simply put. The vestibular spinal system controls balance, whereas the vestibular ocular system controls eye movements and involves a long white matter tracts of the brain. The VOM scoring sheet. Now, this is actually an extremely useful test for diagnosing concussion. And this was initially developed by Musha and Collins at the University of Pittsburgh in 2014. You can print that, you can find this online and just print it out. But what you want to do is you start with your baseline symptoms. This is before the patient is tested. And you can look at, you ask what their headache is on a scale from 0 to 10, what their dizziness is, what their nauseousness is, fogginess, and then any comments. Then the other thing you might want to ask about is as well as eye pain. After that, you look at their smooth pursuits, and it's this is like a very cheap test. You can just take a pencil and you just have them track your finger or a pencil back and forth in both horizontal and vertical direction and see if that provokes headache, dizziness, nauseousness, or fogginess. Then you do the same thing with horizontal saccades and vertical saccades and see if those provoke symptoms. You want to look at near point convergence, which should be less than, like for little kids, should really be 6 centimeters or less. So you have them hold a pencil at arm's length and bring it close, and bring it as close as or you have a tongue depressor with a letter B in about 14-point font, and you just have them bring it as close as possible to their nose. And you ask them at what point the letter splits into 2, and that would be their convergence point. So, I mean, for kids who come, I had kids who have convergence insufficiency. Some kids will be out at 20 centimeters and they're still seeing double. You want to look at your gaze stability. So you look at gaze stability in the horizontal and vertical direction. So you'll have them look at that same letter and then you have them just move their head back and forth at a rate of 60 beats per minute up in the horizontal plane and as well in the vertical plane. And then you look at visual motion sensitivity. And this is a great test for both the vestibular symptoms and oculomotor symptoms. And generally speaking, kids that are not concussed won't have any real provocation of symptoms. Kids that are concussed, you'll see in your office go from like going from normal color to green. And sometimes kids can't even tolerate this exam if they're that concussed. Okay, and so this just goes through the exam once again, just to give you more detailed instructions. So the saccadic movements should be done 3 feet away, 1 feet to the right and left, and convergence talks about your near point convergence point. So actually, and at the bottom, you can see there's a link to the VOMS exam, which you can see there's a nice YouTube video going through this. And other parts of the vestibular testing include the BEST, which is a balance error scoring system. One thing to remember with the BEST is that it's really only useful within 72 hours of injury. Most patients will actually normalize after that. So you can have a patient who's concussed and has a normal BEST exam if they're past the 72-hour time period. The other thing you want to look at is tandem gait with eyes open and closed, and you want to do in Romberg. Okay. Somebody has just asked me a question. I'm going to answer that. I think we're going to answer the questions at the end. Is that correct? Hello? Okay.
Correct. Sorry,
Yeah.
I was on mute. Thank you.
Yeah. Whoops. I'm just gonna, oops, sorry. I'm just trying to get this off my screen.
We cannot see it on our end, just so you know, Dr. Paul. We can only see your slide of how is our patient doing. Yep.
Yeah, no, I know, but I see this. I'm trying to, maybe if I click this again. Nope.
Or if you want to maybe unshare and then reshare, maybe you'll be able to click out of it.
Unshare, let's see. Stop share. Okay. And dismiss, maybe if I dismiss it, no. All right, let me see if I can share this again. Okay. All right, is it shared again? Yeah,
Yes, it is.
yeah, I can't, for some reason, I can't get the, I can't get this out of my screen. Oh, wait, there we go. I just moved it. Perfect. Okay, great. So, oops, now it won't let me go back. Okay. All right. So we had our initial patient who came in, our 16-year-old who was playing ice hockey and had fallen and sustained a concussion. So we asked an initial history, and she mentioned that she doesn't really remember what the play right after her collision, but she did continue playing the game, and she complained of feeling dizzy and foggy during the game. So obviously, if she can, the fact that she continued playing, that puts her at risk of having a more prolonged recovery. When we do cognitive screening, we show that she has no deficits in immediate or delayed recall, but her symptom score is pretty high. It's 18 out of 22. When we do her physical exam, she has no neurologic deficits, but she does have some tenderness on palpation of the right suboccipital muscles and the right cervical paraspinal muscles. And we noticed that on her VOMS exam that she does have significant symptom provocation when we do smooth pursuits and horizontal saccadic movements, and she does have symptom provocation on the VOR. So she does have some gaze instability. And when we do a vestibular assessment, we try to have her walk a straight line with her eyes open and closed. She has multiple errors, and she's unable to walk with her eyes open or closed without having errors, and she's very dizzy. So concussion treatment, if some of your patients, you may want to refer to the emergency department if either you're concerned that they have symptoms that make you think you may want to get a CAT scan, or if they're kind of such a severe headache, you feel like you can't really manage their symptoms as an outpatient. And so those patients should be treated and can be treated in the emergency department, often with IV fluids, with Toradol, sometimes with antiemetics like Zofran. Some patients can have such significant vestibular symptoms that you may want to refer them for neuroimaging. Obviously, any patient who presents with seizure should have neuroimaging. So in terms of headache management, and this is, I think, one of the biggest challenges in outpatient management of concussion patients. One of the biggest things in the initial period, I always say that NSAIDs after the first 48 hours, just because of theoretical risk of bleeding, are fine. You can give NSAIDs and Tylenol initially, and those tend to be fine for most concussion managements. But a certain percentage of patients will say that neither Motrin nor Tylenol really work. So you can try other medications such as subcutaneous triptans or oral triptans, and those work particularly well in patients who present with migraines. And you can do parenteral or abortive medications, and this is really more appropriate in the emergency department. You can do IV diphenhydramine, ketorolac, metoclopramide, ondansetron. Ondansetron you can actually give orally or in the outpatient setting. Reglan actually doesn't really work for headache management if it's given PO. It's more useful if it's given IM or IV. So that's something to keep in mind in the outpatient setting. And actually, one of the other things that I didn't mention here is that actually magnesium and vitamin B2 seem to be particularly helpful in patients who present with concussions. So, and they seem to work more effectively, that I find in my practice, than either ibuprofen or Tylenol. One of the things that you do have to be careful with is that you want to caution patients that after the first 2 weeks, they should really stop taking the NSAIDs or Tylenol on a daily basis, because you want to avoid the risk of developing what we call overuse headaches. So the next thing that we can deal with in the outpatient setting is dizziness. So many concussion patients present with dizziness. Sometimes you can do what's called the Epley maneuver, but that's really more appropriate in patients where you suspect BPPV, which I find not very common in patients who are concussed. You can try meclizine or diazepam, but you have to use that with caution, because many concussion patients are already kind of woozy and feel foggy. So giving them anything that's sedating isn't necessarily what you want to do. So just this is from the emergency department, because in my background, I will tell you that as emergency department physicians, we're very bad at discharging concussed patients. Very few patients actually receive appropriate educational material at discharge, and only 44% actually receive appropriate follow-up. I mean, I'll tell you, like most patients that we see will often have them follow up with their primary care physician, and small percentage will be referred to a concussion specialist or follow up with neurology. And one of the things even to remember in either in outpatient management or in the emergency department is that concussion education has a very beneficial effect on post-sport concussion outcome. The studies have been shown that found that patients who are given very clear educational discharge instructions actually seem to have a more rapid recovery when they actually have a set of expectations in terms of what their recovery time will be, what their symptoms will be, and how they can manage their symptoms. So objectives from when you have a patient who presents to your office or even in the emergency department or in an urgent care setting, the biggest thing you want to do is you want to prevent secondary injury. And this is why we often tell patients that they can't go back to sports until they're cleared by their physician. You want to give guidelines for rest. You want to give guidelines for driving. So actually, very few physicians actually give driving guidelines for their concussion patients, but that happens to be very important because the last thing you want is a concussed patient getting behind the wheel when they have convergence insufficiency, delayed reactive reaction time, and have visual tracking difficulties. You also want to give them appropriate follow-up for symptom-based treatment, and you want to give them appropriate school and work recommendations. So in terms of lifestyle modifications, you want to address proper nutrition. So there have been a number of studies that have come out that have looked at nutraceuticals and supplements in terms of concussion management. Most studies haven't really come up with any definitive recommendations. A lot of things haven't been shown to be that effective, but what has been shown is that, proper, and it's sort of intuitive that proper hydration and proper nutrition is beneficial for proper recovery. A very important thing is to address appropriate sleep hygiene. So your concussed patient will often have disrupted sleep, and they'll be very fatigued. As I said before, you want to discourage them from taking frequent naps during the day. I'd rather have them go to bed earlier at night and sleep longer at night than take naps during the day. If patients are having difficulty falling asleep, you can tell them to take melatonin 1 hour before sleep, and sometimes that can help ease the sleep difficulties that they're having. I really don't recommend any other sleep aids for patients because I feel that those can become addictive, habit forming, and don't necessarily help in terms of sleep hygiene. And you also want to give them instructions, and they shouldn't be on their screens anyway, but you want to tell them they should not be on computer screens for an hour before bed. And you want to make sure that every patient is informed about expectations for concussion recovery. So I often will tell patients that based on their age and their symptoms, usually they'll get better within 7 to 10 days. I tell parents of younger children that they can expect their child may be symptomatic for 3 to 4 weeks, and they shouldn't be alarmed if they're still having a headache 2 to 3 weeks in. And that actually helps to address their expectations, and they're not as worried when their child isn't better yet after 2 to 3 weeks. You also want to reduce their symptom load. And this is sort of in terms of going back to school. So for nausea and dizziness, what I often will tell patients is, first of all, when they go to school, they should be able to leave class 5 minutes before the end of class so they can avoid busy hallways. If they're staying school long enough to eat lunch, you want them to have lunch in a quiet place. You can recommend that if things are really noisy or difficult, that they can bring headphones or noise canceling headphones. And I would say that students who are in school where they take band or orchestra, they should avoid those classes. In terms of light sensitivity, if your patients come in with severe light sensitivity, they can wear sunglasses, although I recommend that if they're inside a building, they try to avoid becoming too dependent on sunglasses because it can take longer for them to have the light sensitivity go away. So I only try to encourage sunglass use outside. If they're complaining of blurry vision, and you should always, one thing I didn't add, you should always do a vision assessment when your concussed patient comes into the office. So you want to recommend reading is tolerated. You want to recommend using audiobooks as much as possible, You can consider an ophthalmology consult if you notice changes in accommodation. You want to recommend that if they are on a computer screen, that they increase the font, or that they print out all their assignments be printed out in a larger font so that they do work on paper instead of doing work on computer screens. If they're complaining of convergence insufficiency, I recommend prism glasses or readers. They can see a neuro-optometrist for that, or an ophthalmologist to get prescriptions. And sometimes vision therapy, although it's very controversial whether that's beneficial or not. The other thing is, in terms of treatment, if they have severe vestibular ocular motor impairment, you can recommend vestibular physical therapy. And if they have cervicogenic symptoms. So if your patient comes in like the 16-year-old and she had tenderness along the suboccipital muscles in her back, in her neck, sometimes manual therapy can help with that as well. If they have impaired concentration, I would say no testing or exams in school. I'm sorry, I'm just going to actually turn on the light in the background. It got kind of dark in here. Okay, and that they should they should have no standardized testing, no SATs, no ACTs until they're ready to handle that kind of testing. And your patients may need accommodations to repeat assignments, and they may need additional repetition or assistance. And it's very important that you actually you are your patient's best advocate. Some schools are great about giving students accommodations for concussions. Some are not so great. So you always have to be on top of that and really work with the family and the student to make sure that they get appropriate accommodations. And if they have impaired balance, you want to have them avoid risky activities. I've had lots of parents ask me if their kids can go bike riding while they're concussed because they're really bored and they want to go back to sports. But I generally say, like, if their balance is that impaired, they really shouldn't be on a bicycle. So screens and concussions. So it's become more of an issue now with COVID, even post-COVID, because patients have, we now have so many more Zoom lectures than we did before. So there's no official research that showed any detrimental effect of electronic use in sport-related concussion recovery. However, more recent data has showed that in the immediate post-concussion period, you really do want to avoid screens because use of screens in the immediate post-concussion period has been shown to delay recovery. It's really important that you work, and this is especially with adolescents, that you work with them to allow them to have some kind of connection with their peers by phone. So I always recommend that they can text with their friends. If the text messages are getting to be like essays on their phone, that what they should do is text and tell their friend, hey, can we just talk instead of texting? But I just tell them to generally avoid like any kind of, scrolling like through social media, Instagram, Facebook, YouTube videos. Those tend to make symptoms worse. And there actually are accommodations that exist for screen viewing. So there are kind of paper-like screens that patients can use now. They're like almost like Kindles, and those can, and especially in patients that have post-concussion symptoms and really need to be on a screen, those can be helpful. So you can, as I said, you can reduce the brightness, increase the font size. You can wear light filtering glasses such as Theraspecs and take frequent screen breaks. So in terms of medication use, we kind of touched on that before. Unfortunately, there's no medication that cures concussions, but there are medications that certainly can make concussion symptoms more tolerable. So you want to consider, in certain cases, we have used neurostimulants like amantadine just to help with concentration. I have had patients who I've started on Lexapro because they do suffer from depression secondary to their concussion. You want to avoid overuse syndrome with ibuprofen and acetaminophen, and so you can consider magnesium and B2 for headaches. And you always want to address the underlying cause, because many times the headaches and fatigue that a lot of the patients are experiencing are really from underlying issues. For example, they have difficulties with smooth pursuits. They have difficulty with saccades. They may have a cervicogenic concussion and you haven't addressed their neck. So you want to make sure you address all these before jumping just to medication. In terms of return to learn, we always want to encourage early but limited return to school. So I always say in my office, I do 24 to 48 hours of strict rest. And if the patients can tolerate it, I'd have them go back initially for half days as tolerated, then 3/4 days, then full days. You want to make sure that you lessen the workload, and taking standardized tests should be deferred. And remember that patients have to be cleared for school before sports, but they can perform light aerobic activity. So you don't want patients being completely inactive after their concussion, because it's been shown that actually light aerobic activity reduces recovery time from concussion. So it's actually really important for your patients to start doing some light exercise as they can tolerate it. As I said, in terms of learning accommodations, as we discussed before, you want a shortened day with focus on only core classes, shortening assignments. You want to have written instructions rather than computer assignments, and lunch and rest breaks in a quiet place. One of the other things that I can tell you that I find very helpful, just in terms of printouts, and the schools seem to find this easy to use, is the ACE concussion form. And you can get this online pretty easily. You can print it out. It actually gives you really clear concussion instructions for the school. So we talked about this. We mentioned this before. As I said before, light aerobic exercise daily has been shown to be beneficial in concussion recovery. So now that we've talked about concussion diagnosis as well as concussion treatment, what about concussion prevention? How can we prevent concussions? There are, a lot of parents will come in and ask you about Q collars. They'll ask you about mouth guards. They'll ask you about helmets. So really the best way to prevent concussion is proper sportsmanship and technique. That's really the best way to prevent concussions. And I can tell you that in this post-COVID year, I think I saw more concussions in my private practice than I had ever seen before. And I think this is in part because everybody was so eager to go back to sport and try new things. And all these kids who had never played football before were suddenly playing football. So those kids didn't really start playing. They didn't really have proper sportsmanship and technique. So they had a much higher risk of becoming injured because they weren't properly prepared. Just to remember, mouth guards prevent dental trauma and not concussions. Q collars, I feel very uncomfortable recommending, just in terms of basically a Q collar. It's a device that basically you put around the neck. It's used often more with lacrosse players, although I've seen some football players use it as well. The whole idea is that it presses on the external jugular to basically keep blood flow in the brain, so that you have kind of like a balloon, so that you have an extra cushion for the brain to kind of have extra support or cushioning, so that you get less likely to be concussed. But I feel uncomfortable with anything that obstructs blood flow to the brain. In terms of legislation, there's been a lot of changes in legislations for trying to keep kids safe in sports. These include heading the ball. So kids under 10 no longer can head the ball in soccer. Body checking is prohibited in kids 12 and under. And hopefully there'll be additional legislation for lacrosse helmets with girls, and further things will come up to actually make sports safe for kids. And there's still a lot of controversy, there are a lot of patients, a lot of people who feel that kids shouldn't be playing football anymore. But I don't think I don't think football is ever going to go away. And I don't think contact sports are ever going to go away. So I think the best approach is really to understand how we can quickly diagnose and treat concussions to allow kids to play sports safely. So take-home points are that sports-related concussions are common. Most concussions resolve within 7 to 14 days, but younger children and teens can take longer. 20% of patients will actually go on to develop what are called post-concussion symptoms. Concussions can have many signs and symptoms, but they do follow a pattern, and it's important to determine what type of concussion your patient has. Imaging is not useful in diagnosis, and it's important to note that concussions are now treatable. We don't have to lock kids in a dark room and let them do nothing until they start feeling better. Kids can take an active role in their recovery. And this is our final slide. No more. So if anybody has any questions, I'd be happy to answer them.
Great, thank you so much for Dr. Paul. Dr. Paul, we really appreciate it. So just a few questions in the chat. So the first one we have is, A doctor has a 16-year-old female with a third concussion secondary to soccer in the past 3 years. Second concussion took a 3-month recovery period. Third concussion is taking 2 weeks with vision therapy recommended due to mild nystagmus. Sorry, I said that wrong. Yep. At what point would you say no more soccer? I understand it may be subjective and you may need more information.
Yeah, so she's had 3 concussions in the past 3 years. I guess in this case, so part of the question, there's 2 parts to this question. First of all, is were the concussions kind of stacked together? So if I have, for example, if I had a patient who had 3 concussions within a year, I would probably say at that point, no more soccer. If those were 3 concussions within 5 years, for example, if they were widely spread apart, I would probably be less likely to say no more soccer. The other thing that I tend to look at is how long they took to recover. So honestly, if I have a patient who had a 3-month recovery period and now they're on their 3rd concussion, I think in those cases, I would be more likely to tell a mom, I really recommend that they try to, pursue a non-contact sport rather than soccer, especially since, she's 16, obviously she's in an age where, the kids head the ball at this point, there's much more contact involved, so.
And they did follow up that they've been about a year apart. So I don't know if that changes anything.
So as I said, so if it's a year apart, I'd be less likely to say that they'd have to stop playing soccer. However, the length of the recovery time makes me concerned. And so I think after the 3rd concussion, I would say that they should probably pursue a different sport. But, it's so difficult to get parents, I think most of the time they really don't listen to these recommendations. So that's been my biggest challenge. I have a patient now who plays football. He's now on his 3rd concussion, and his 2nd concussion took 4 months, and now he's severely symptomatic. I'm trying to convince mom that he really has to stop playing football, and I have to tell you, it's very challenging.
Okay, thank you. If you want to stop screen sharing while you are talking as well, you're welcome to.
Stop share. Okay. Okay, there we go.
Perfect. All right. So next question is, let's see, is what is in quotes the immediate concussion period? How is it determined?
So I would say within, and this is with respect to what?
I will let you know if they follow up with more in the chat. That's all. That was the only part of the question that was received so far. While they follow up in the chat, just to move on to the next question, we have for a while computerized tests like impact were being given before sports seasons and then used post-concussion if needed. What are your thoughts on these?
Yeah, so impact is actually no longer routine. I think it's still used by a lot of schools. But I will tell you that, for example, NYU's Concussion Center, and I think even Boston Children's, a lot of concussion centers no longer use impact to diagnose or do baseline testing. I personally find the impact test useful in the sense that it's good for provocative testing. So if I give a student or an athlete an impact test and I find that they're incredibly symptomatic after the impact test, for me that's a positive flag and they're definitely concussed. But there's a lot of test to test variability. So you can have a healthy patient take an impact test on a Tuesday and repeat the same impact test on a Thursday and have completely different results. So I find that I do have some issues with the validity of the impact test. So we don't tend to use it as much anymore.
All right, thank you. Next we have what cognitive therapy can help in quotes brain fog. I have a 19-year-old patient 11 weeks out with residual memory and confusion issues.
So, I mean, I think in that case, I'd recommend, in those cases, I do recommend neuropsych testing to help, and then think that can help guide cognitive therapy.
Okay, let's see, there's a couple more that are sent in. So I know.
Sorry, actually, and in that case also, I think if they're 19, if they're in college, I mean, it's really important. So it's important to work with that patient in terms of giving them guidelines in terms of how they can manage their schoolwork, their classes, and how they can function within their academic environment. So that's also very important.
Perfect, thank you. Next, you said magnesium and vitamin B is often useful for concussion patients with headaches. Is it also helpful for patients who have migraines or
Yes.
headaches without concussions? And if so, what type of magnesium do you recommend?
So typically magnesium glycinate is the formulation that's recommended. And magnesium and B2 has been shown actually to be very helpful even with patients with migraines. In fact, I think even in the emergency department setting, you can give them an IV infusion of magnesium and sometimes it can help.
Thank you. Next, we have, how does age of the patient affect the approach to the concussed child? An evaluation to go back to return to activity.
So that's a great question. So the younger they are, the more challenging it is. I think, for kids that come in who are, early school, like, I don't know, 4, 5, 6 years of age, actually those kids are harder to do a concussion assessment with, because you can imagine trying to do, a visual tracking exam with that age patient can be more challenging. In those cases, I think it has to be really guided by how, parents know their kids best. And so you have to look at the kid, their child's behavior in terms of their irritability, how they can, if they're complaining of headache, how they can tolerate activities, and when parents feel like the kids are actually back to their baseline, I think in those cases they can return to full play. I mean, fortunately, the younger they are, the less likely it is that they're engaging in contact sports. I tend to say that they can go to school, and you don't want to isolate them, so they can definitely go to school, but I tend to keep them out of recess, or like after school sports.
All right, thank you. And then one other one that we had, so when compared to similar sports, girls have a higher rate of concussion than boys. Why is that?
That's a great question. So there are a lot of different theories for that. One is difference, there are hormonal differences between girls and boys, men and women. And so that's thought to contribute to their having a more prolonged concussion recovery. And actually, one of the things that's really important with that is knowing that is telling parents that, or patients, that they may actually have changes in their menstrual cycles. So sometimes they'll skip a period, or they'll have prolonged periods during their concussion. So that's something to keep in mind. Some people argue that females have like weaker cervical musculature, and so they have weaker neck muscles, so that can contribute more to having a more prolonged recovery and make them more likely to be concussed. And the other thing is that girls are more likely to report their symptoms than boys, and so maybe it's a part of it may be more subjective.
All right, thank you. Does anyone else have any further questions that they'd like to put in the chat or in the Q&A box?
Okay, Dr. Paul, thank you so much.
Oh,
that was
my
a
pleasure.
great presentation. Are you taking new patients?
Yes,
Can
I
we
am.
easily refer? Okay.
Yes.
We will clearly work that out. Just, I guess, one little simple last question for me. Evaluating these kids, the pediatrician really creates a lot of angst, right? And then time constraints. What would you suggest to try to relieve some of this angst? The go-to test, or the history itself, what part of it is the red flag, go to the ER, or you need to see the concussion specialist?
Well, go to the ER well, first of all, go to the ER is more about timing. So for example, if they're coming in a week after they were concussed, chances are at that point, I'm not as concerned about, a traumatic, a brain bleed at that point. So at that point, the concern is really to refer them to the emergency department, more because they're having severe symptoms than anything else, and symptoms that you can't really manage in an outpatient setting. So their headache is like an 8 out of 10. They can barely function. They're miserable. And so in that point, they may need to have abortive treatment, like, IV fluids and Toradol, and, just something to help break the headache. So,
Mhm.
so those things would make me want to, and also I think if you're in your office and it was within 24 hours after sustaining a head injury and they have a completely abnormal neuro exam and they can't walk a straight line, I think I might refer them to the emergency department to have neuroimaging. So those are kind of red flags in my mind. Obviously, if they come to you the same day and they're, complaining of a persistently worsening headache, they seem out of it, they have an abnormal neuro exam, those patients should just go straight to the emergency department. I wouldn't even second guess that for a minute. In terms of when to refer them to a concussion specialist, I think, if it gets to the point, if it's with that, so that's kind of, there are two sides to that. I feel like my biggest kind of not so much pet peeve, but issue, I guess my biggest frustration is when I have patients who have been suffering, I guess, with symptoms for 3 to 4 weeks and haven't seen a specialist, haven't gotten, have sort of been kind of like limping along with their symptoms, because I feel like the sooner you get them in to see somebody, the sooner they get treatment, the faster they get better. So I feel like it's better to err on the side of sending somebody in too early rather than too late. On average, I think for me, it takes me about 45 minutes, to an hour to see, to really, especially if it's a more complicated concussion patient, to do a really thorough concussion evaluation, as well as going through kind of, school accommodations, sports accommodations, athletic accommodations. So it does take a certain amount of, it does take a decent amount of time, but I think addressing issues earlier rather than later is really important.
Great, all good advice. Thank you so much again. We're coming to a hard stop, so we would love to invite you back in the future, and hopefully that, or whenever you're ready, please don't hesitate when new things come up. And I'd like to say good night to all of our attendees tonight. At the top, we had about 54, so it's not too bad. Just want to let you know how we did. And good night, everyone, and we'll see you all next month.
Okay. Good night. Thank you very much for having me. Bye-bye.
Bye-bye.